Today we are discussing about the anatomy and surgical anatomy of breast and how to examine it. Okay, so this is a very important topic as breast malignancy these days is very highest in the female group. Okay, though breast malignancy can be both in the male and female, but in female because the tissue is more, so the incidence is more. So introduction. As you see in this diagram, what is breast? It is a modified sweat gland. Okay. In male and immature females, it is rudimentary or atrophic. After puberty, female breasts are fully developed. Now we come to the surgical anatomy. It lies in the superficial fascia of pectoral region. Okay. Now what is the extent of breast? Vertically means from upside and down, it's from the second to sixth ribs. Horizontally, lateral border of sternum to mid-axillary line or anterior axillary line sometimes. In pregnancy, it goes up to mid-axillary line. Then, one most important thing which is usually seen in the malignancies is TDLU, terminal ductal lobular unit. This is the area where malignancy starts. Okay. So, what is the mammary bed? That is the bed on which breast lies. It rests upon the following structure. The major muscle that is known as pectoralis major muscle, it is present in the medial 2/3 of breast and laterally it is a serratus anterior muscle. So remember these two muscles. Because when we examine the breast, when we see the fixity to muscles, then these two muscles are there. Then external oblique aponeurosis, it is in the inferior middle. It means it is in the inferior side. So it's self-explanatory. There are milk ducts, areola, nipple and fatty tissue. Now what is the importance of retromammary space? This is the space where lymphatics lie. It intervenes between the base of the gland and deep fascia covering the mammary bed, and lymphatics are present here. Why this space is important? Because all the malignancies, all the cancers, they spread through these lymphatics and they go to the axilla and other areas. So in this diagram you can see retromammary space, skin, fatty matrix, then suspensory ligament, glandular tissue, then areola, nipple, and there is one lobe, opening of lactiferous ducts at the summit of nipple, lactiferous sinus are there, then main lactiferous ducts and smaller ductules. This is a section which is sagittal section, it means it's going like this. So if you see like this, you can see all the ribs, clavicle, second rib, up to sixth rib. So that's how we can see the extent of breast. Then pectoral fascia, which overlies the pectoral muscles, premammary fascia, then suspensory ligaments of Cooper, ampulla, which include nipple and areola, lactiferous ducts, and subcutaneous fat. Okay. Now, what is the new word here is suspensory ligament of Cooper. Why it is important? Because if any malignancy or any chronic inflammatory condition involves this, then there can be a dimpling in the breast, which is a very important clinical sign of malignancy. Now, broadly it is divided into 4 quadrants: upper inner, upper outer, lower outer and lower inner. And in the axilla it is axillary tail of Spence, which is the extension of breast only. Okay. Now the question which is asked is in which quadrant there are maximum chances of malignancy? Can anybody tell? It is the upper outer quadrant. Why? Because there is a axillary tail of Spence, the tissue is more, so incidence is more in this quadrant. Okay, the upper lateral quadrant has a lateral extension as we discussed. It is known as axillary tail of Spence. It enters into axilla through a foramen which is known as foramen of linga. It has direct communication with the anterior group of axillary nodes. In the subsequent slides, we see how many group of lymph nodes are there in the axilla. Now, this is a basic structural unit of breast which is known as a lobule of breast. 10 to 100 lobules empties into a one lactiferous duct, and total there are 15 to 20 lactiferous ducts which open in the nipple. These ducts are aware of milk and abnormal discharges, okay, which are seen in the fibroadenosis. Okay. Now, as you see in this picture, there are lobular cells, lobules, ductules, and then ducts. Okay. Now, here we see what is the importance of ligament of Cooper. It is a hollow conical projection of fibrous tissue filled with breast tissue. The apices of cones are attached firmly to the superficial fascia and thereby to the overlying skin. These account for dimpling of skin of overlying carcinoma. Whenever there is malignancy and breast tissue is got involved, these ligaments which are filled with the mammary tissue, these also get involved. And because of fibrosis, they pull inwards, producing a dimpling in the breast. Now, what is the importance of areola? It contains involuntary muscles. Its epithelium contains several sweat glands and sebaceous glands, though breast is a modification of sweat gland. Later, it enlarges during pregnancy and serves as lubrication of nipple during lactation. And there are glands in this which produces sebum. Okay, these are known as Montgomery glands. And during pregnancy, these becomes more enlarged and known as Montgomery tubercles. Now, how the muscles are arranged in the nipple? The nipple is covered by a thick skin with congruations. It contains smooth muscle fibers arranged circumferentially. Okay, and longitudinal muscle fibers arranged vertically. Near its apex lies the orifices of lactiferous ducts, and that's why it's a protuberance or protruding structure. Now we come to the arterial supply of breast. What can be the arterial supply? Axillary artery, which is mainly present in the axilla. The branches from this artery supplies breast. Superior thoracic, thoracoacromial, and lateral thoracic artery. Then branches from the internal thoracic artery, which is below the ribs, and then laterally from the intercostal arteries, second to fourth ribs. Venous drainage corresponds to the arterial drainage because lymph nodes lie along these veins. They first converge around nipple to form an anastomotic venous circle and then form two sets of veins. One is superficial and another is deep vein. Superficial ones drain into internal thoracic vein and lower part of the neck. Deep veins also drain into thoracic but also in the axillary and posterior intercostal veins. This is very important. Lymphatic drainage. The lymphatics of the breast drain predominantly into axillary and internal mammary group of lymph nodes. Okay. The axillary nodes receive approximately 85% of the drainage. So, in metastasis, these are the utmost importance. Here we can see different groups: internal mammary, then lateral axillary, central axillary, anterior axillary, apical, and supraclavicular. Subsequently, when we go in the inspection, I will tell you where they lie. Now, axillary lymph nodes can be arranged in following groups. Lateral group along the axillary vein. This forms the superior lateral boundary of the axilla. That's why lateral boundary is axillary vein. Anteriorly along thoracic vessels. Posteriorly along subscapular vessels. Central is embedded in the fat in the center of axilla. Interpectoral group, it means between pectoralis major and minor. That is also known as Rotor's lymph nodes. Okay, those lie between minor and major. Then apical lymph node, which lies above the level of pectoralis minor. The apical nodes are also in continuity with the supraclavicular lymph nodes, and they drain into subclavian lymph trunk, which enter green veins directly via the thoracic duct or jugular trunk. The sentinel node is defined as the first lymph node draining the tumor bearing area. Okay. So what is the importance of sentinel lymph node? That in these days, if the patient present with the initial stage of malignancy, we go for a sentinel lymph node biopsy. If it is not involved, it means we don't have to go for the axillary dissection because it is the first lymph node. If it is free from the tumor, then no point in going ahead. If it is involved, then we have to go for the axillary clearance. And in many other malignancies also, like in CA penis, CA colon, the sentinel lymph nodes are of utmost importance. The research is going on. Internal memory lymph nodes are very few in number, and it is very difficult to palpate them because they are usually underlying the ribs. So how to detect them? We have to go for a percussion, and if there is a dull note in percussion, then it means these internal memory lymph nodes are enlarged. Now, surgically, axillary lymph nodes are classified into 3 levels. Surgically means when we operate, then these are arranged in 3 groups. So, at least level 1 and level 2, we have to send for this lymph node sampling. And if it is a clear-cut malignancy or involvement, then only we have to go for level 3. So, where is level 1? It is below and lateral to the lateral border of pectoralis minor. Level 2 in front and behind pectoralis minor, also including the rotor's lymph node which lies between the pectoralis major and minor muscles. Then level 3 above and medial to the medial border of pectoralis minor. Now, how to do a breast assessment? There is a triple assessment. First is clinical, second is imaging or radiological assessment, and third is pathology, that is histopathological. These 3 assessments clinch the diagnosis up to 99.9% of the cases. So what we do in the clinical assessment, it is age and examination. Age means if older is the age group, that is common for the carcinoma breast. Younger is the age group, more aggressive is the disease. Okay. Then on examination, if you suspect that what is the hallmark of malignancy, if the lump is hard, if the lump has no clear-cut boundaries, it is fixed to the breast tissue or fixed to the chest, then we have a suspicion for malignancy. So we go for the imaging. What is important in imaging is either we should go for a USG, that is mammography, that is X-ray mammography. X-ray mammography in few countries is also a screening program like in Japan. But why we don't use in India? Because it also misses the 5% of malignancies. That's why whenever there is a suspicion, we go for the ultrasound and mammography, and a combined report is given. In pathology point of view, either FNAC or core cut biopsy. What is the difference between FNAC and core cut biopsy? In FNAC, it is only a cytological study. Only cells are there. So we are not able to know about whether there is a capsular invasion or not. What is the hormonal status, because that requires a tissue. What hormonal status? ER, PR and Herceptin. So core cut biopsy is better than FNAC. So core cut biopsy has a tissue, and all the things which are done on histopathology can be done on the samples of core cut biopsy. And these all 3 assessment gives a confident diagnosis of 99.9%. It cannot be 100%, but it is near to that. Now we come to the clinical examination. Physical examination of breast that have 4 components: inspection, palpation, percussion and auscultation. Right? But whenever the patient first comes to you, what is the way of breast examination? It is a dial method. Why the dial method is follow? because if there is a centimetric lump, if you go haphazardly, you are likely to miss many lumps. Okay, so we should not miss any tissue or any lump. That's why there should be a particular direction. So starting from the one as the dial clock is there, you palpate the breast so that you doesn't miss, and lastly you have to palpate for the areola. Because what happens in Paget's disease or Paget's malignancy, these are retroareolar and they are very likely to be missed, and they usually present with a stage 4. So that's why there is a dial method, and lastly nipple and areola, and then axilla examination. Now we come to radiological imaging, which what we discussed, ultrasound. Ultrasound is particularly useful in young women. Why? Because there is a dense breast and mammography is not possible. In whom mammograms are difficult to interpret and distinguishing cyst from the solid lesion. USG is the best modality to differentiate between a cystic and a solid structure. It can also be used to localize impalpable areas of breast pathology. Suppose if you clinically miss a lung, that can be picked on a sonography. So that's why it's required. Mammography. These are the soft tissue radiographs and are taken by placing the breast in direct contact with the ultra-sensitive film, and the X-ray image is produced. Okay. But what is the quality of this X-ray? This is low voltage and high ampere X-rays. Okay. It means that it is more focused or more informative about the soft tissues than bone. Even 5% of the breast cancer are missed on the population screening programs. Now MRI. It is not a routine investigation of breast, but in some cases it is required. Firstly, suppose if there is a post-operative patient and patient comes to you after 6 months, then USG cannot differentiate it between whether it is a scar or it is a malignancy. So that's where MRI is required. To distinguish a scar from recurrence in women who had previous breast conservation therapy, to assess multifocal and multicentricity. Okay. Multifocal means in the different quadrants of breast. Multicentricity means in the same quadrant but there are few lumps, more than one number of lumps. So those are picked up in the MRI. Okay. Then it is less useful in low grade DCIS. It is the best imaging modality for the women with implants, because USG cannot give an answer for that. There is a overlapping of the implant with the other nodules. So MRI is the best investigation for that. And also, if the patient has a high or very strong family history, then they should be screened by MRI only, because in family history we have to pick sub-centimetric lumps also, which are not picked up on the USG one. Now there is a system which is known as BI-RAD system on USG and mammography. The full form of BI-RAD is Breast Imaging Reporting and Data System. It is used to categorize the degree of suspicion of malignancy for a mammographic abnormality. This scoring helps in taking clinical decisions. Mean to say, clinical decision means whether to operate, whether to go for a conservative therapy, or whether to go for a quadrantectomy. So these are the final assessment categories. In BI-RAD 0 lesion, it means the tissue is not well reported and not contained in the core cut biopsy. So repeat core cut biopsy is required. So it has no significance. Grade 1 is BI-RAD's grade 1 is, it means it is a negative for malignancy. Essentially 0% malignancy is there. If it is a benign lesion grade 2, it means malignancy is 0%, but routine screening, yearly routine screening is required. Third is probably benign. Here 6-month follow-up is required, not yearly, but less than 2% chances of malignancy, because the blood is probably benign. Then fourth is suspicious. Here tissue diagnosis is required. Okay. So what action is taken if it is grade 4, go for a core biopsy. Okay. Now grade 4 is divided into three parts. 4A means low suspicion for malignancy, that is 2 to 10%. 4B category is moderate suspicion, that is 10% to 50%. And 4C 50 to 95%. Then grade 5 is highly suggestive of malignancy. Tissue diagnosis is must and more than 95%. There is no category 6, but if patient comes with a previous histopathology report, that is come in the grade 6. So surgical excision is required because patient has already the histopathology report. This is the histopathological examination on FNAC. Here you see the rapid and it is very rapid and accurate for both operator and cytologists are experienced. Because if there is a no cytologist, then it is very difficult to pick up malignancy on the cells or single cell. However, false negative reports may come because it is a very small needle and it may possible that you didn't pierce the core cut or core of the tumor. Okay. So that's why in these days in breast, the role of FNAC is very less. We should directly go for true-cut or core cut biopsies. This is the core needle biopsy. This is the investigation of choice and it is recommended to use a 14 gauge needle, while in FNAC it was a 23 gauge. This can be done under USG guidance because here also it is possible if the lump is small, we have to pierce the core of that lump and that can be USG guided. In this, the core biopsy, the tissue is coming, that's why it's used for differentiation between DCIs and invasive disease, which is not possible on FNAC. Lastly, if a patient comes to us and we offer for a excisional biopsy, this is the gold standard because we are sending all the surrounding tissue along with the core. That's why if this is reported negative, it means it is 100% negative. Only even on core biopsy, it may possible that you miss some focus of malignancy. Now these are large needle biopsies of the centimetric or subcentimetric lumps. Okay. These are known as VAP system, vacuum assisted biopsy. What happens in there? That there is a 1 centimeter circumference, there is a core needle gun in which there is a cutter and which is moving and a vacuum which sucks this 1 centimeter lesion into it and we cut that whole lesion, which is not possible in the core cut biopsy or even in the open biopsy because it is very likely that we will miss the small lump. Now we come to clinical examination. Local examination. What is the prerequisite? Patient must be stripped with a waist to expose completely both breasts before inspection is commenced. As you know, in inspection we are not supposed to touch the patient. We only have a visual impression. There must be adequate privacy so patient can be relaxed. Examining area must be well lighted. Examination is performed with patient in. See how important it is. There are 5 positions. One is supine, one is sitting. Okay, these are very simple. Then one is semi-recumbent position, recumbent position, and bending forward. Every position has its own importance. What we want to say. If there is an inspection in 5 position, there must be sub-importance for every position. Now this is carried out with arms by the side of body, arms raised straight above the head, hands on our hips pressing and relaxing as the surgeon commands, and with the patient bending forward. Now why arms by the side of the body? Because by this manner we can see the symmetry of both the breasts. If one is higher, one is lower, it means there is some fibrosis or some process is going on this breast. When we raise arms straight above the head, if there is a lower quadrant lesion or lower quadrant malignation, that breast will be low at the lower level than the normal breast on raising the head. So we can pick up that there is a lesion in the lower quadrant.
Okay. Till that time, I will show you why the patient should put hands over his hips, because by pressing this and by movement of patient, we can see whether the breast is fixed to the muscle or the breast lump which is fixed to the tissue. Okay. If it is fixed to the muscle, then we ask the patient to bend forward, the breast will not move. Okay, because it is the malignancy is fixed to the pectoral muscles or serratus muscles. Okay. Then on bending forward, what happens if the nipple is involved there? If the nipple is involved, it will not fall forward on bending forward in the malignancy side. Okay. That can be demonstrated in the clinical postings, because it is very difficult to demonstrate. You have to understand here. Now, in this case, this shows the retraction of nipple. Okay. Retraction of nipple can be in cases of either a benign disease or a malignant disease. In malignant disease, it is circumferential retraction, between whole of the nipple is in. In cases of benign diseases, only a slit-like retraction is there. Okay, it is not 360-degree retraction. So that is the difference. Now you should look for the, on inspection we are saying you should look for the skin over the breast. Color and texture, because there is a venous congestion is there, or malignancy is there, or because of the hemosiderin there can be. Engorged veins can be there. Dimple retraction or puckering is there. Why there is a dimple formation? Because of the involvement of Cooper's glands or Cooper ligaments, as we discussed. Puckering is because of the involvement of the superficial fascia. Then a point which is shown in this diagram is PUD orange. Actually the pronunciation is PUD orange, it's not PUD orange. Okay. Why this appearance is there? It is because of the involvement of the subcuticular lymphatics. Then why this appearance come? Because of this subcuticular involvement of lymphatics, the hair roots present in the dermis and the superficial tissue get edematous, so there is a dimpling of that hair. So that's why it is a PUD orange. Then there can be some nodules known as satellite nodules because of the secondary malignancy. Sometimes because of the involvement of malignancy, there is ulcerations. Now, how to differentiate between the ulceration of a benign condition and pressure necrosis and a involvement by malignancy? In benign condition, if you take a probe, you can pass between the skin and the ulcer. But in malignancy, because of involvement, you cannot pass that probe between the skin and the tumor. It means it is malignancy. Then here you can see retraction of nipple with PUD orange appearance. Okay. In nipple, what we have to inspect: presence, if it is there or not, or amesia, position, number, size and shape, surface and discharge. Position can be there, it is central or off midline because of the fibrosis. There along the mammary niche there can be many supranumerary nipples, so number is also to be seen. Size and shape. If the nipple is protruding, it means we are dealing with the Paget disease. If it is retracted, it means in the inner quadrants there is a malignancy. Surface means if there is a eczema or any other skin condition, if some discharge is coming out of it, then it is C. And lastly, discharge. Discharge means if it is a bloody discharge, there is a strong suspicion of malignancy. If it is a green or yellowish discharge, it means either fibroadenosis or some pus infection is there. Now areola, you can see color, size, surface and texture. We already discussed Montgomery tubercles. Then why to look for the arm and thorax? Because if malignancy has invaded all the lymph nodes, the arm lymphatic also drain into axillary lymph node and there will be edema over the arm. And if malignancy is spread through the lymphatics, then there can be a multiple nodules over the arm, that is known as cancer and cuirasse. Okay. Then we should look for the axilla and supraclavicular fossa, because supraclavicular lymph node that is also have a connection with the infraclavicular lymph nodes. Now we come to palpation part. Okay. On palpation, all the inspectory findings are confirmed on palpation. In palpation, in sitting position, palpate the normal breast first. Then it should be done with the palmar surface of fingers with the hand flat. Now, can you tell me what is the difference between flat of hand and hand flat? Anybody? So this is a very important terminology, how to palpate the breast. See, this is the flat of hand. Okay. And hand flat means your fingers should be flat. So palpate the breast with fingers with flat. Okay. With hand flat. Flat of hand is this. Palmar aspect. So remember that. All the four quadrants of breast should be palpated. And just behind the nipple also because of the Paget's disease. Okay. And also look for the nipple discharge while palpating. If it is a green discharge, it means we are dealing with a fibroadenosis, which is a benign condition. Or if it is a yellowish one, it means there is a duct ectasia or periductal mastitis, that is an infective condition. If it is a bloody discharge or red discharge, it means either we are dealing with a papilloma of intraductal papilloma of breast or frank malignancy. So, bloody discharge is very important. Local temperature and tenderness, okay, to rule out the inflammatory condition from the malignancy. Only in one malignancy, which is known as inflammatory malignancy of breast, which is the worst prognosis, in that case also there is a raise in temperature, otherwise it's only in the inflammatory condition. Then situation of the lung. Carcinoma is mostly found in upper and outer quadrant. Okay, that we have already discussed because the tissue is more. Fibroadenomas are found in the lower part of breast. The number of lumps, size, shape, surface, margin, as a swelling we have already discussed. Consistency, fluctuation, transillumination test, fixity to skin, fixity to breast tissue, fixity to underlying fascia, fixity to chest wall, and palpation of the nipple. Now, how to look for the fixity to the breast tissue? So, whenever there is a lung, first we go look for the consistency. Consistency means how the lung feels. If it is soft in consistency, it means it is a lipoma or any other sebaceous cyst. If it is a firm consistency, it means it is a fibroadenoma. If it is a hard consistency, it means either it is a periductal mastitis tumor or malignancy. If it is a bony hard tumor, then definitely it is going in favor of malignancy. So that is the importance of consistency. Then importance of fixity to skin. If the tumor is fixed to skin, then on inspection there will be a 2D orange appearance. If we try to put the skin over that lung, we cannot pick it. It means skin is involved. How to look for the fixity to breast tissue? By one hand you hold the breast and with the other hand you hold the lung and you try to move. If it's not freely moving or moving along with the breast, it means it is fixed to the breast tissue. How to look for the fixity to underlying fascia and muscles? Ask the patient to relax. Just hold the breast and move it. It moves sideways. Then ask the patient to press firmly on the waist or hips. And ask the patient to, or we can even feel the breast and try to move. If it is not moving in any direction or restriction of movement, it means it is fixed to the muscles. Because by this maneuver, we made the muscles taut and the breast is also not moving along with muscle. When we remove the hands and still there is a mobility, it means breast is fixed to the muscles. If it is fixed to the fascia and not to the underlying muscles, it means there is a restricted mobility in both the directions. Okay, but there is not a full mobility. It means the muscles are spared in this. If it is fixed to muscle, in all the directions there is no mobility. If it is fixed to chest wall, how will you differentiate? Either you press the hands or don't press, it will be fixed to the chest wall in anyhow. In relaxed condition also you are not able to move because the ribs are fixed structure, chest wall contain rib and muscles. So if it is fixed to chest wall, it is already stage 4, nothing has to be done. Then lastly, you have to palpate the nipple because you think that the tumor is in the other quadrants, but very importantly, you can miss the retroareolar tumor. So it is must to feel the nipple also. Then on general examination, in carcinoma breast, liver, lungs and bones, particularly the ribs, spine, sternum, pelvis, upper end of femur and humerus for metastasis. Okay. How can we know? You ask the patient if you have a pain anywhere in the body. If she says, then it is a metastatic tumor. Rectal and vaginal examination to detect Krukenberg's tumor of ovary. Okay. This is a transcellular spread. In gynecomastia, in males, hysterosterostrol for management of CA prostate. Testes should also be examined. If there is atrophic testis, that can result into the gynecomastia. Associated leprosy, but that is very rare these days. Certain drugs which are very important like digitalis, spironolactone, isoniazid and some few other steroids. So if the patient is taking that can result into the gynecomastia. Okay. So this is up to the general examination. Now, how to look for the axilla? See, if we stand like this, this is the anterior group, this muscle, this is the anterior group, okay? This is the posterior group, posterior fold of axilla. This is brachial or lateral group. This is medial group. And if you feel here at the apex, this is central group. If you fix the shoulder and push your hand more upper, then you feel the apical group. And if apical group is also invaded, then you can feel the supraclavicular lymph nodes in the middle of the clavicle. So these are the lymph node mechanisms. Okay. And on inspection, on palpation, we see there are some conditions like percussion. What can we find on percussion? Suppose if internal memory lymph nodes are enlarged. In axilla we can feel, but how can you feel the internal memory when they are below the ribs? So importance of percussion is there. If there is a dull note in the intercostal spaces, it means internal memory lymph nodes are enlarged. We are talking clinically, not by USG. Okay. And if there is a hyperdynamic structure like sarcoma breast or other condition, then that can be detected on the auscultation. Okay. If there is a hyperdynamic circulation. So in the next class we will learn about how to manage these carcinomas and what is the treatment for that. And now you go and read from your DAS because clinical examination is huge for the breast. Even in the inspection also there are 5 positions. Okay. In the exam also we ask in how many positions you go for that. So that is must. In next class for 5 minutes we will revise this and then we will go for that. And whenever you are supposed to come to OPD, then in groups you can come. On patient we can show you or we can demonstrate you that this is the method how we can say. In a theory class it's very difficult to demonstrate all these inspectory finding or palpatory finding. So thank you very much.